ఈ పక్కకు తీసేయ్. మధ్యలో వస్తుంది. Start करूँ. Hello everyone. Good afternoon. I'm Dr. Pranitha, consultant neonatologist and pediatrician, KIMS Kondapur. Today I'm going to talk about delayed lactation and low milk supply. So when do we say, how do we define delayed lactation? When mother's milk doesn't undergo the expected rise within the first 72 hours postpartum, it is defined as delayed lactation. So to understand that better, we need to understand the physiology of lactation, which includes 4 stages. Stage 1 or lactogenesis 1 starts in the antenatal period itself within the first 16 to 20 weeks of pregnancy. This is also known as secretory differentiation. It is driven by the high levels of estrogen and progesterone. But secretions in this phase are held back because of the high levels of progesterone. And the thick colostrum in this phase facilitates for better sucking, swallowing coordination in the newborn infant. The stage 2 is lactogenesis 2, which is also called as secretory activation, which starts day 3 postpartum and extends till day 8. Here, there is onset of copious amount of milk production, mainly under the hormonal influence of prolactin. Progesterone starts declining during this phase, and there is programmed transformation of mammary epithelium. The third stage is lactogenesis 3 or galactopoiesis, which starts from day 9 till involution. Here, there is maintenance of established milk supply. So in this phase, the milk control changes from endocrine control to autocrine and local control. Stage 4 on involution is from 40 days after the last breastfeeding. In this phase, there is increased amount of feedback inhibitor of lactation. So what causes delayed lactation? Lactation is mainly because of delay in lactogenesis 2. So how do we know that mother is getting in milk or there is coming in of milk? Mother usually has symptoms like fullness of breast, heaviness, warmth, tingling, engorgement. There is leakage of milk from the opposite breast, which she is sucking, which the baby is latching on. And there is also change in baby's feeding patterns and behavior at the breast. And there is change in appearance of milk also from thicker golden colostrum to thinner white mature milk. And the quantity of milk during the first day, it's only 2 to 10 ml. It progressively increases by day 7 to 30 to 60 ml. But how do we quantify milk? We cannot completely like express milk and see how much is the milk coming. So the only good indicator that mother is getting enough milk is baby's weight gain. Since most of these things are subjective, the only good indicator is baby's weight gain and baby's urine output. So let us see the systemic analysis and meta-analysis which is done on the factors which is causing delayed onset of lactation. First, when a mother complains of delayed lactation, we should start with the history. So in mostly primary mothers, there can be delayed lactation by 1 day because of longer delivery times which result in higher amount of cortisol. History of breastfeeding difficulties in previous newborn should again alert us to this. Some medical conditions like hypothyroidism and other hormonal conditions like diabetes, insulin resistance, PCOS, or chronic illnesses like cystic fibrosis should also alert us that this mother needs little more extra support during her lactation journey. Obesity pre-pregnancy, especially during the puberty, can result in lesser amount of breast development. And if it is not managed well postnatally, it can also result in delayed lactation. There is also decreased prolactin response to suck. Other medical conditions during pregnancy like gestational diabetes and pregnancy-induced hypertension can also result in delayed lactation. There can be certain anatomical abnormalities in mother, like mother who has undergone a breast surgery, or if there is flat nipple, inverted nipple, mismatch between the mother's nipple size and baby's mouth, though not very significant, can also result in delayed lactation. Certain anatomical abnormalities where there is tubular bliss with hypoplasia in the inner quadrant and lower inner and lower outer quadrants can also result in delayed lactation. What are the complications during the delivery process which can result in delayed lactation? LSCS deliveries, especially if it is unscheduled, because again there is number of interventions done during the delivery process. Like there is also prolonged stage 2. There is mother is given a lot of IV fluids, anesthesia. There is pain. Again, there is increased amount of stress hormones. These can also cause delayed lactation in a mother who has undergone cesarean section. Apart from that, baby mothers with the premature deliveries, because there is again lesser preparation, the lactogenesis stage 1 is shortened in preterm labors. Also, lactogenesis stage 2 is delayed. The onset is delayed in 80% of these cases. Again, there is the stress of baby in an ICU, which can result in delayed lactation. Then multiple babies or twins or triplet deliveries can result in more complications, preterm deliveries, and again predisposed to delayed lactation. Certain other perinatal complications like postpartum hemorrhage, PIH, shock, or puerperal sepsis in mother can result in delayed lactation. Sheehan syndrome, which is caused because of secondary to PPH, which results in necrosis of pituitary, thereby resulting in hypoprolactinemia, can also lead to delayed lactation. Then, what are the postnatal complications which can lead to delayed lactation? Retention of placenta, because again here the progesterone levels do not decrease, and then there is delay in the onset of lactogenesis phase 2. Mother infant separation, either because the mother is sick or the baby is sick. Then delayed milk expression, not effective latch in the first 24 hours, improper breastfeeding guidance in the hospital. There is a decrease of frequency of feeds, poor sleep in mother, which can result in poor prolactin production, and certain drugs like oral contraceptive pills, Sudafed, that is nasal decongestants, can also lead to decrease in milk production. Then there are certain other secondary problems like sore nipples, breast engorgement, blocked ducts, and inflamed breast tissue, that is mastitis, which can lead to delayed lactation. So we define lactation insufficiency into one where there is primary lactation insufficiency, where there is failure of lactogenesis phase 1 and 2. Here, it might be because of the anatomical problems, the ones which we discussed, like hypoplastic breasts or surgery done on the mother, like mastectomy, cyst removal. Hormonal factors, because of retained placenta, is one of the very common cause. Apart from that, hypothyroidism, PCOS, diabetes, stress can all lead to primary lactation insufficiency. Secondary lactation insufficiency is because of failure of lactogenesis 3. Here, the breasts are not drained sufficiently, and hence, feedback inhibitor of lactation builds up. This can be because of many reasons like poor attachment, use of formula feeds, supplemental feeds, or other infant health problems. So, prevalence is about 15% in primiparous mothers of term infants. Let us see some infant or neonate related factors which can predispose to delayed lactation, mainly because of poor sucking skills of the baby. Either if a baby is born small for gestational age, large for gestational age, babies who are born IUGR or preterm deliveries can all have poor sucking skills. Babies who are born with syndromes like Down syndrome, Turner syndrome, Beckwith-Wiedemann syndrome can all have poor sucking skills because of poor oromotor coordination, large tongue, glossoptosis, or either because of hypotonia. All this can result in delayed lactation in mother. Then certain anatomical problems like cleft lip, cleft palate. Then here the right picture is showing Beckwith-Wiedemann with the macroglossia, or babies with tongue tie. Babies with Peary-Robin syndrome, where there can be both glossoptosis causing obstruction of the oral cavity. Apart from that, they can also have micrognathia and cleft lip or cleft palate, which can lead to, again, poor sucking. Then babies with the neurological issues, like babies born with asphyxia, and babies with hypertonia, babies with hypotonia due to any other neurological reason. Babies with secondary problems because of excessive weight loss, or babies who are given supplemental feeds, formula feeds, bottle feeds, babies who are given nipple shields or other things can also have delayed lactation. Now, let us go to how to manage this mothers who come with complaining of delayed lactation. So, first thing is to confirm if it is true low milk supply or is it just perception of low milk supply, which can happen in almost most of the mothers. So, as we discussed, poor weight gain in baby, especially if it is also associated with oliguria, is the only reliable indicator of low milk supply. Rest of the all the things are mostly subjective. So, the only objective finding is poor weight gain in baby, who's if the baby is on exclusive mother's milk. So, do we need to do any investigations? We need to investigate, especially if we are suspecting some hormonal issue. We can check the thyroid levels, prolactin levels. Testosterone can be checked if you are suspecting PCOS. In a mother with the diabetes or GDM, we can check the sugar levels. And ultrasound can be done to check for any retained placenta. So, what are the interventions which we can do to improve this delayed lactation? The first and foremost thing which we have to do is educate the mothers antenatally. Antenatal education is much more important and much more plays a significant role in improving the mother's lactation journey other than postnatal lactation education. The one intervention which all of us can practice immediately after delivery is providing skin to skin contact of the baby with mother, especially if the baby is born term with good cry and tone. The Cochrane suggests that in babies who are given skin to skin contact just after the delivery, breastfeeding after the postpartum period, there is increased breastfeeding rates of almost 1.24 times. And the duration of breastfeeding journey has also increased by 42 days. Script score, which is the measure of the baby's vital parameters, is also more stable in babies who are given skin to skin contact. And the sugar levels are also stable in these babies. The second thing is to understand about the oxytocin reflex. The oxytocin levels are stimulated if the mother thinks of the baby, the sound of the baby, sight of the baby, being confident about baby care. And it is inhibited if the mother is worried, stressful, in pain, in doubt. So, how do we increase the amount of oxytocin? By promoting again skin to skin contact, kangaroo mother care in premature born babies, bonding with the baby, doing some back massages for mother can also help. And again, pain management, which is often neglected, will also increase the oxytocin levels in mother. The other thing is the prolactin levels are higher during the night time. So most of the mothers, especially babies who are born preterm, may not express in the night time. So night feeds and night expression should always be promoted in mothers. Nursing more frequently, that is at least 1.5 to 2 hours during the daytime, and at least every 3 hourly during the night should be promoted, because the more the baby nurses at the breast, there is more demand for the milk and there is more production of the milk. If the milk is not removed properly, it will cause an increase in the feedback inhibitor of lactation levels, which causes decreased in milk production. In mothers who there is frequent milk removal, there is prolactin receptor activation, and this will promote increased milk production. Also, pumping at least till 5 minutes after the last drop will help in increasing the milk production. Then again, we need to check baby's weight, and if baby's weight is exceeding weight loss of 2% per day or cumulative weight loss of almost 7 to 10%, then always assess the feeding adequacy. The most common cause in most of these cases is still ineffective suck and poor latch. So that should be checked in every visit and corrected. Promoting expressed mother's milk itself, and supplemental feeds should be given only if medically indicated. So again, we need to check the latch of the baby and check the attachment in each of our follow-up. The other things which we can do, which can improve the lactation, is by offering both sides of the breast switch nursing, where we switch sides 2 or more times when the baby is stopping feeding in between. Also, compression of the breast tissue will also increase the milk transfer. In babies who are born premature or babies who have neurological issues, hypotonia, or syndromic babies, or babies with anatomical problems, promote expression of breast milk. Avoid pacifiers, bottles, nipple shields. And also, it is important for mothers to take rest, relax, and have adequate sleep in between. Supplemental nursing system is another thing which can help in these cases. So in supplemental nursing system, the indications are mothers with low milk supply or babies who are born preterm, or for inducing of lactation or relactation, and for helping in increasing of milk production after breast surgery. So this is an indigenously prepared supplemental nursing system with the help of a NG tube. Does giving extra fluids for mother increase the milk production? So the Cochrane says it is not so. So there is no the effect of it is not a very physiological thing, and increasing the hydration status is not correlating with increased milk production. Then coming to the galactagogues, which we should be the final resort only after correcting and treating all the other things which we just discussed. So the pharmacological galactagogues which are most commonly used are domperidone, metoclopramide, sulpiride, growth hormone, recombinant human prolactin, thyrotropic releasing hormone, and metformin. But among this, the most commonly used are still only domperidone and metoclopramide, and we do not have evidence to promote the other drugs. The herbal galactagogues, which are most commonly used, are shatavari, which is asparagus, fenugreek, moringa, garlic, cumin seeds, dill seeds, and ginger. So galactagogues act by increasing the amount of prolactin level in the mother. So domperidone is still the most extensively studied and most commonly used galactagogue. It's a dopamine receptor antagonist. It stimulates the pituitary release of prolactin. And prolactin promotes the closure of epithelial tight junctions between alveolar cells and increases the synthesis of alpha-lactalbumin. So in most of the studies, domperidone is usually commenced from day 2 to day 3, and it is used till day 28. The dose most commonly used is 10 mg thrice a day initially to a maximum of 20 mg thrice a day. The duration used is almost 7 to 28 days, and the onset of action is seen within 7 to 14 days. So this is the systemic review which is done on which includes 3 RCTs with 150 mothers of preterm babies. Domstol is given 10 mg thrice a day for 7 to 14 days, and there is average milk volume per day increases by 40 to 160 ml. There is no difference in breastfeeding rates. So domperidone is certainly useful in mothers with preterm babies. So what is the checklist which we should follow before prescribing domperidone? Always screen for any cardiac arrhythmias and prolonged QTC. Some studies they have also monitored by checking the ECG levels before prescribing domperidone, and then during whenever we are giving domperidone, we need to keep monitoring for the ECG and also check for side effects, especially if there is previous history of arrhythmias in the family. Mothers who are high risk, if we are using very high dose of domstol, if there are any symptoms, or if mother is on any other CYP3A4 inhibitors. The dosage again should be started with lowest possible dose, and then we should taper rather than stopping suddenly. Metoclopramide is another drug which is used. So most studies used a dose of 10 mg thrice a day for 5 to 21 days. The increase in milk volume is seen with a dose of 30 mg dose and not with the dose which we use commonly, which is 10 mg. But when we use dose at such high levels, the metoclopramide crosses blood-brain barrier, and it causes a lot of CNS-related side effects in mothers like postpartum depression, tardive dyskinesia, tiredness, headache, and nausea. And it is also secreted breast milk. So when we compare domstol with metoclopramide, domstol is a much more safer drug, and it is better to prescribe domperidone. And it is better to avoid metoclopramide. As such, the mothers who usually have a lot of postpartum depression, so we shouldn't further worsen it by giving the galactose, which have not much proven efficacy. So Cochrane also shows that galactagogues, especially in mothers of non-hospitalized term infants, doesn't have any significant benefit. So the benefit is undoubtedly proven in preterm mothers, but the benefit is not much proven in babies in who are born term. Now let's see some other herbal galactagogues. The fenugreek is again a very common thing which is used. It is commonly consumed by Indian cuisine and it is traditionally used to enhance milk production. So it can be taken as a herbal tea and it is generally well tolerated. The side effects are most common one is diarrhea and there can be unusual body odor. Shatavari, which is taken from asparagus roots, is another common thing which is used in India most frequently for promoting lactation. And other things are like garlic, moringa, cumin seeds, ginger, which have been also used to promote lactation. But the problem is most of these herbal preparations, there is lack of regulation since they are herbal preparations. And also there are not many studies done exclusively on them to show that they have any proven safety or efficacy. Protocol, it is American Breastfeeding Association, also doesn't promote the use of galactagogues for maintaining milk production in mothers. So to summarize, if the mother complains of low milk supply, first see if it is really low milk supply or is it just perceived low milk supply. If there is no evidence of low milk supply, reassure the mother. Know the cause of low milk supply. Is it any medical cause, anatomical cause, or infant related cause? And treat it accordingly. Compulsorily, we need to evaluate the feeding process thoroughly. If there is any modifiable factors, treat them. And medications are never a replacement for evaluation and counseling the mother. So this completes my talk on delayed lactation. Thank you very much for joining.